Good morning, everyone. I'm Michael Cacoilo, and
Siegel.
We are third-year residents at the Swedish Cherry Hill Family Medicine Residency Program, and our continuity clinic is based out of Seymour Community Health Center. And we are going to be presenting today on adolescent trauma, specifically talking about screening and treatment in the primary care setting. And we chose this topic because we both have a strong interest in adolescent health and trauma-informed care. We have found through our own experiences in clinic that patient encounters in which trauma exposure has been disclosed have been particularly challenging to navigate. And we wanted to expand our own understanding of the evidence-based practices in assessing for trauma in adolescents, and to equip us as primary care providers to be able to offer supportive and timely intervention for our patients. So thank you for joining us this morning. And so in terms of our objectives for this presentation, we hope that by the end of this talk, folks will be able to recognize common manifestations of trauma in youth, describe the utility and limitations of trauma screening measures, understand core concepts of trauma-informed care, describe evidence-based treatments for trauma-exposed youth, and identify ways that primary care providers can promote resilience among trauma-exposed youth. And so just so that folks are aware, this presentation will cover a wide range of traumatic experiences that may impact children and adolescents, and make reference to some of the following topics, so just for folks to be aware of that. And so as primary care providers, we're in a unique position to interface with youth. During our routine health supervision visits, we take on this massive task of assessing our patients' overall health and well-being, covering topics of nutrition and sleep quality and social support systems, academic difficulties. And for many of our patients, we can be regarded as trusted adult figures in their lives, and our clinics can be considered, may be considered a safe place for children and adolescents. And for some patients, their primary care provider might be the first person that they disclose to about a traumatic event. And we're thankfully, through continuity of care, we have the ability to be able to build these long-term supportive relationships with our patients, which can be particularly important for seeing someone through a healing process of working through trauma-related experiences. And so for these reasons, it's really important that we recognize our role in providing support and meaningful intervention for our patients. And so as we get into the content a little bit further, wanted to just start out by clarifying some terminology around this topic of trauma that can sometimes be used interchangeably, but has important distinctions that we'd like to point out. So many of us are familiar with the term ACEs, or adverse childhood experiences. This was a term coined by researchers during a sentinel study in the late 90s about assessing the prevalence of specific types of adverse experiences in childhood, such as physical abuse or exposure to substance abuse in the home. And an important finding from this study was that ACEs in childhood were correlated with a variety of health morbidities in adulthood. And what we often refer to as ACEs are actually a smaller subset of a much broader category of experiences that fall within the realm of childhood adversity. And so childhood adversity refers to a wide range of experiences that can threaten a child's physical or psychological well-being. And so in addition to those types of experiences that are labeled as ACEs, other types of childhood adversity can include bullying, natural disasters, poverty, medical illness, among many others. And it's important to note that there's a great deal of variability um, among the outcomes of children who are exposed to adversity, and that experience of childhood adversity does not predestine negative outcomes. When we're talking about trauma, oh, sorry, when we're talking about trauma, we're specifically talking about the experience of the individual. So trauma occurs when a child experiences an event as extremely frightening or threatening to their life or safety. It's important to note that witnessing a loved one threatened or harmed can also invoke trauma for children, as their sense of security is often very closely connected to the safety of their attachment figures. Um, and trauma affects, it's important to note that a specific event may affect children differently. Some of them may experience a particular event as traumatic, while others may not. The impact of trauma on a child or on a family, it can be based on a variety of factors, at the individual level, as at the family level, and in terms of their environment regarding their support systems. Um, when we talk about toxic stress, what we're referring to is an overactivation of the physiologic stress response system. And this can be seen in situations, particularly with exposure to chronic severe trauma over time. And so when we're talking about potentially traumatic events, um, as I mentioned, it really has more to do with someone's experience of trauma, not specifically the event itself, but there are certain types of events that can have a greater likelihood of invoking a traumatic response. This list is not exhaustive, and it's important to note some things that like experiences of violence or neglect, experiences of war-related trauma. Something to note as well is the sudden loss of a caregiver, either through death of a parent, for example, or abrupt removal of a caregiver figure from the home in the form of incarceration or deportation, for example. Um, and it's important for us to also recognize how racism plays a role in um, children's experiences of or children's risk of experiencing some of these events in the way that systems of racial injustice are interwoven into many of these experiences as well. When we're talking about um, how prevalent this is, what is the impact of trauma among children? Epidemiologic studies estimate that up to 70% of US children and adolescents experience some form of trauma. Um, and we recognize that trauma that occurs during childhood or adolescence could impact critical windows of neurodevelopment, where various regions of the brain are undergoing extensive synapse formation, dendritic branching, and the physiologic stress response, the release of stress hormones that occurs during trauma can disrupt these essential processes in development. In particular, when we think of dysregulation of the hypothalamic pituitary adrenal axis, we recognize that that can have widespread impacts on cognition as well as metabolic processes. Um, and we're not going to get too far into the details of the extensive morbidities that can be associated with these changes, just for us to recognize that trauma can result in pretty pervasive effects across psychological well-being in the form of mood disorders and many other mental health concerns as well, behavioral functioning, people's ability to form supportive relationships. And when we talk about long-term impacts on physical health and morbidity, conditions that have been linked directly to trauma include things like cardiovascular disease and asthma, among many others. And so it's important to note that following trauma, children and adolescents can have variable responses. But the most direct and systemic pattern of symptoms that may result from trauma is in the form of PTSD. So we'd like to briefly review some of the diagnostic criteria of PTSD. In 2013, the DSM-5 moved PTSD from the category of anxiety disorders to its own to a separate category altogether called trauma and stress-related disorders, which includes acute stress disorder as well as adjustment disorders. And one big change that was made at the time of that switch was also the definition of exposure to trauma. The events that specifically qualify as a traumatic event can be the direct experience of threatened death, injury, or violence, or witnessing this occurring to someone else, learning that something violent has occurred to a loved one, even if not directly witnessed, or repeated exposure to details of traumatic events, such as in the case of first responders. And when we talk about symptoms of post-traumatic stress disorder, we're breaking them down into 4 clusters of symptoms. So for example, intrusion symptoms can include flashbacks or nightmares. Avoidance symptoms, where the child or adolescent is avoiding reminders of the traumatic event, and this can include people that remind them of the trauma or places or activities. Negative alterations in cognition and mood, such as self-blame, persistent shame or anger, feeling detached from others. Alterations in arousal and reactivity can include an exaggerated startle response, difficulties with concentration. And it's important to note that the duration of symptoms is important. In the first 4 weeks following a traumatic event, these symptoms can all be present, but they would be considered an acute stress disorder. If it lasts beyond 4 weeks and patients are meeting all of these criteria, it is diagnosed as PTSD. And with all other disorders, what qualifies it as a disorder is that it is extremely disruptive to one's important functioning in daily life. And it's also important to note that these symptoms, in order to meet this diagnostic criteria, can't be attributable to other medical conditions or substance use, which, as we'll get into shortly, it's tough because there is often a bit of overlap between PTSD and substance use in adolescents. And so when we talk about the rates of PTSD, estimates show that PTSD affects about 5% of US adolescents, and of youth who are exposed to trauma, many recover without developing PTSD. And it's unclear the percentage of adolescents who go on to develop PTSD following an exposure to trauma. In a meta-analysis conducted in 1994, it was estimated that up to 36% of youth exposed to trauma went on to develop PTSD. However, there was wide variability in estimates among the studies pooled for that meta-analysis in 1994. A more recent meta-analysis in 2014 sought to establish the risk of PTSD in children and adolescents exposed to trauma using well-established diagnostic interviews that researchers pulled a total of 43 studies from peer-reviewed journals between the years of 1994 and 2012, when the DSM-4 criteria were in effect. And most samples were from the UK, the US, and Australia. The participants were all aged from 2 to 18 years old, and this was from sample populations of children and adolescents that were not specifically seeking mental health services. And there was pretty broad diversity in the types of traumatic experiences that people had, and they were categorized as either interpersonal, which included things like war, injury due to violence, and non-interpersonal, such as natural disasters, medical illness, And it turns out that when they pulled all of these studies, that the overall risk of adolescents who were exposed, of children and adolescents who were exposed to trauma going on to develop clinically diagnosed PTSD was 15.9%. Um, there was quite a bit of heterogeneity across samples, and so specific moderators were further analyzed and showed that youth who were exposed to interpersonal trauma had a much greater risk of developing PTSD compared to youth that were exposed to non-interpersonal trauma. There was also a difference seen in that girls tended to have a higher risk of developing PTSD following trauma exposure compared to boys. And so we'll go into a little bit more detail about that here. So as we see, just recalling that 15.9% was the overall general rate of developing PTSD. However, when we look at the rate of developing PTSD with exposure to interpersonal trauma, that came out to 1 in 4 adolescents exposed to interpersonal trauma, whereas more like 1 in 10 adolescents exposed to non-interpersonal trauma, such as like a car accident or medical illness. The difference between girls and boys across the study samples is almost a 2-to-1 difference in that 1 in 5 girls versus closer to 1 in 10 boys would go on to develop PTSD. And when and looking at boys who experience non-interpersonal trauma having the lowest risk of lowest rates of developing PTSD at 8.4%, whereas girls exposed to interpersonal trauma almost a 1 in 3 rate of developing PTSD. And it's not entirely clear as to why these patterns emerged, but in terms of the in terms of our understanding of the risk of interpersonal trauma going on to have a higher rates of PTSD. It's thought that interpersonal trauma can tend to be more chronic, such as violence in the home, and often erodes our social support systems, especially when the perpetrator is a family member, um, and can sometimes lead to more self-blame, this sense of a betrayal of trust, this shattering of assumptions of what's to be expected in the world. Regarding differences across boys and girls in these studies, it's much further research is needed to really clarify why those differences are seen. Um, uh, it's thought that some hypotheses are that boys might have a higher likelihood of externalizing behaviors, whereas girls might have a bit more of a tendency for internalizing behaviors that can be seen more with PTSD. And there's also a possible role for the influence of sex hormones in the risk of dysregulation of the HPA axis, making girls more susceptible. And so aside from symptoms of PTSD, youth exposed to trauma can experience a broad range of symptoms. They may present with significant anxiety or panic attacks. Youth exposed to trauma are also at higher risk for comorbid depression, and many traumatized youth might actually develop depression in the absence of other PTSD symptoms. It's important to note that depression in trauma-exposed youth can be more refractory to treatment than depression in youth who have not experienced trauma. Um, and a really important thing that I do want to highlight is that adolescents exposed to trauma are at increased risk for suicide, even in the absence of depression. They have a risk of more severe suicidal ideation, more attempts, and more frequent self-injurious behavior compared to peers who are not exposed to trauma. So it's really critical to screen specifically for suicidality and self-harm in any adolescent with a trauma history, even if they're not presenting with depression. Um, there is also a marked increase in the risk for substance use disorders, in particular early use of substances among trauma-exposed youth. And this is thought to be related to a self-medication hypothesis of using substances to relieve symptoms. There is also an increased risk for reactive aggression among youth exposed to trauma. And this is thought to be multifactorial, and part of it being related to trauma's neurobiologic effects, in that youth who have experienced trauma and are in and might be more in their uh, like have an easier activation of their sympathetic nervous system through a fight or flight response. Um, and there is also evidence that psychosis can be comorbid with PTSD as well, both in the form of positive symptoms like hallucinations as well as negative symptoms such as withdrawal, flattening of affect. Psychosis overlapping with PTSD, it tends to be seen more in youth who have experienced intentional harm and targeted violence. Youth might also be presenting to clinic without any of other kind of mental health symptoms, but might be presenting with more somatic symptoms of headache or constipation or other things that don't necessarily have a really clear explanation as to why that's going on. And that might clue us in that something else, that there's been some sort of trauma exposure. Youth exposed to trauma might be presenting with signs of academic difficulty or not attending their classes, being late to school often, and might also be presenting with some high-risk sexual behavior during adolescence. And so when we talk about screening in the primary care setting, it's important for us to recognize that youth who have experienced trauma are unlikely to volunteer this trauma history if they're not specifically asked. And so while there are not formal guidelines on screening for trauma in children and adolescents, the American Academy of Pediatrics suggests that given the data on the frequency of child and adolescent exposure to traumatic events, it's not unreasonable to consider screening for trauma during every health visit. And some researchers pose that an option for how to screen more universally would be like asking children or adolescents a simple question such as, since the last time I saw you, has anything really scary or upsetting happened to you or your family? This wouldn't necessarily catch everyone because sometimes trauma happens well before the initial establishment of care with a pediatric or adolescent provider. But this is one example of a simple screening question that can be asked at every visit. When we think about universal screening, this can help to remove a sense of stigma or judgment, reassure patients and families that talking about traumatic experiences is integrated into their overall health and well-being, and that's why we're talking about it. And I'm not going to talk about there are a lot of well-validated measures that are available to help us in assessing for trauma exposure and symptoms in adolescents. The National Child Traumatic Stress Network has a database that reviews various tools that can help in assessing exposure and symptoms, and the National Center for PTSD through the Department of Veterans Affairs also provides some information about trauma and PTSD assessments that can be used with children and adolescents in accordance with DSM-5 criteria. For the purposes of our talk today, we're going to be focusing specifically on one measure of trauma exposure and symptoms known as the Child Adolescent Trauma Screen, or CATS. CATS is a short questionnaire that's based on DSM-5 criteria for PTSD. This is a tool that Bella and I have personally incorporated into our own practice with adolescent patients, and it's received quite a bit of research attention, especially in recent years. It's been shown to have international validation in samples in the US and Norway and Germany. It definitely still needs validation studies in other languages, but it's reasonable to consider as a screening tool and for symptom monitoring. So the first part of the CATS questionnaire involves assessing for exposure to potentially traumatic events and prompts youth to answer yes or no if a particular event did or did not happen to them. It's a set of 15 questions. And then at the end asks the ask the patient which one of these is bothering you the most right now. And if they answer yes to any of these items, they then move on to answering questions about symptoms. Here's an example of how the form looks on page 1, that asks adolescents or asks patients about exposure to any of these types of experiences. And then when they're being asked about symptoms, there are a total of 20 items corresponding to those 4 symptom clusters in the DSM-5, including intrusion symptoms, avoidance symptoms, changes in mood and cognition. And then asks the participant to identify on a scale from 0 to 3 how badly these symptoms have bothered them over the past 2 weeks. And a clinical score is one that's considered when the score is 15 or higher. And this is an example of some of those symptoms that that people might be experiencing. In terms and following asking about symptoms, the last part of the CATS questionnaire involves assessing for interference in key areas of functioning, such as school or work or relationships. And so when we're talking about how to best assess for trauma exposure and PTSD symptoms in youth, we recognize that there are different measures that are available. And there was a study that was done in 2017 that compared 5 measures for assessing for trauma exposure and PTSD symptoms in youth. The first 3 of which were completed directly by youth as self-reports. There was one that was completed by a caregiver and one that was completed by a teacher who had a lot of exposure with this, who worked often with the child. And all of these different types of measures were compared with a gold standard diagnostic interview for PTSD based on DSM-4 criteria. And this study specifically was looking at a population of youth aged 11 to 18 who were presenting for outpatient mental health services. And just some key findings of this study was that youth report of their own symptoms was a strong predictor of having PTSD. However, it's important to note that 1 in 4 youth meeting diagnostic criteria for PTSD based on that gold standard diagnostic interview actually did not report a traumatic event when prompted on a questionnaire about exposure to trauma. So keeping that in mind, it's really important to know that even if youth are not specifically disclosing that they have experienced a trauma, they might still be experiencing significant symptoms related to trauma. And it was also found that combining scales did not improve prediction of PTSD, such that combining a scale completed by the youth and with their teacher or caregiver did not necessarily improve improve diagnosis. And just briefly to touch on this concept of upset that can result from screening. Sometimes we are concerned that asking adolescents or asking youth about traumatic experiences can result in high degrees of emotional distress and upset following the screening itself. A recent study in 2019 in a population in Norway of greater than 10,000 participants who were presenting for outpatient mental health treatment and completed a CATS questionnaire were then asked about levels of upset from the screening. And about 79% of those screened completing the CATS questionnaire screened positive for at least one potentially traumatic event, but the majority did not have significant levels of upset following screening. Those that did have significant levels of upset tended to have higher levels of PTSD symptoms and tended to have higher exposure to interpersonal trauma. So this is just important for us to take into account when we recognize that the importance of screening youth who have higher risk of developing PTSD might result in some emotional upset, but those youth who tend to be emotionally upset after screening also tend to be the ones probably most in need of intervention. And so just some practical considerations for how we can implement screening for trauma using measures into a routine clinic visit. It's possible to consider doing this as a routine part of our intake for wellness visits with youth. If so, it's important that the youth complete the self-report form alone without a caregiver present. And it's also reasonable upon coming into the room and talking with the patient to discuss to discuss confidentiality before looking at the form to review their responses. And so at this point, I'm going to turn it over to Bella, who's going to be talking with us about trauma-informed care.
So, trauma-informed care. The Substance Abuse and Mental Health Services Administration, or SAMHSA, contextualizes this trauma-informed care approach to encompass 4 assumptions: realizing the widespread impact of trauma, recognizing signs and symptoms of trauma, responding by fully integrating what we know about trauma into our policies, procedures, and practices, and seeking to actively resist retraumatization. So negative interactions in the healthcare setting can lead to poor outcomes, treatment non-adherence, or even complete avoidance of the medical system. So it's really important for us to be aware of all the elements of healthcare encounters that could potentially trigger patients who've experienced trauma. This could be certain sights, smells, sounds in the clinic during our exams, removal of clothing, touch, asking personal questions. A lot of us already incorporate elements of trauma-informed care into our practice, but we wanted to offer some additional tools to consider. Starting from the pre-visit, making sure we do a thorough review of any trauma-related history so that our patients don't have to repeat themselves. During the encounter, positioning ourselves in a way that reduces an already existing power differential. So that might be sitting at eye level. A patient might have a preference to sit by the door or even have the door slightly open during their visit. During the physical exam, asking permission before doing each part of the exam and having the patient shift their own clothing or gown. For more invasive exams or procedures, describing any sounds or sensations they might experience. For example, the feeling of cold gel or the click of a speculum. Another thing we can do is offer suggestions instead of giving instructions. So something I tend to say a lot is take a deep breath, but instead we can offer, some people find it helpful to take a deep breath. When it comes to imaging, it's really important to alert our patients if imaging might be invasive, like a transvaginal ultrasound, or constrictive, like an MRI. And for referrals, it's important to notify our specialists in advance of any relevant trauma history that may impact their care. And for the post-visit, some of our patients experience high levels of anxiety or even dissociation during a healthcare visit, in which case it can be helpful to have written summary instructions that they can review when they're in a more comfortable setting. Something Mike touched on earlier was confidentiality. So a unique challenge of caring for youth is creating this environment where they feel safe and it's a trusting environment where they can share their truth, but while also being transparent about the limits of confidentiality, because we're also responsible for ensuring their safety and fulfilling certain professional and legal obligations. So we wanted to offer this as an example of language you can use to discuss confidentiality. Everything you share with me during your visit will stay in the room unless I have a concern about your safety. So once an adolescent has disclosed a specific trauma or screened positive for trauma, the first priority should be making sure they're safe. So we should be asking ourselves, are they safe to go home? Are they at imminent risk of additional harm? Might they be punished or harmed for disclosing any abuse or trauma, or potentially coerced or intimidated to recant the disclosure? If we answer yes or maybe to any of these questions, then CPS or law enforcement should be contacted immediately while they're still in the clinic. So we wanted to present this case. A 14-year-old comes in for a routine wellness visit. They're recently having more difficulties getting to school on time. They're endorsing some intermittent headaches, stomach upset, otherwise nothing on their review systems. Their exam is normal. You decide to perform a CAT screen, and they disclose a history of physical abuse that occurred 5 years ago. The abuse wasn't reported at the time. They don't feel comfortable naming the perpetrator, but assure you that they no longer have contact and they feel safe going home. So what would be your next step? A, the abuse is not ongoing, therefore not reportable. B, continue to build rapport with the patient and report to CPS once you have more information. C, report to CPS before a youth leaves the clinic. And D, report to CPS within 48 hours. And you can go ahead and you should be able to click directly through Zoom. Okay, so I see most people chose B. So the answer is actually report to CPS within 48 hours. So as a reminder, physicians, we're all mandated reporters. And if there is reasonable cause to believe that a child has suffered abuse or neglect, or may be at risk for abuse or neglect, the report must be made at the first opportunity, but in no case longer than 48 hours. So in this case, you have a young person who's disclosed a history of abuse. You don't have any immediate safety concerns, but this does still fall under something that's reportable. And if you're feeling unsure or skeptical of whether something will actually be investigated, it's still important to report. We have a legal obligation to report. And it's really up to CPS to decide how to proceed with an investigation. And having said that, reporting can be challenging for a number of reasons. Something I already touched on is that you have a young person who's entrusted you with this really sensitive information. And I think Mike and I have both experienced that it can sometimes feel like a betrayal to then take that information and share it with other people. So again, that's why it's so important to be upfront about the limitations of confidentiality. Another way to try to maintain that trust that was offered by Jasmine Zavala, the adolescent medicine specialist at CMAR, is that you can offer to make a report together with your adolescent patient so that they don't feel like you're going behind their back. And another challenge is addressing a situation like this in a busy clinic schedule. So part of a trauma-informed care approach is making sure that your clinic has the flexibility and resources to appropriately respond to a situation like this. So things to consider are, would you be able to shift patients to a different provider schedule or reschedule them altogether? How can you communicate that you have a patient in crisis to your support staff in a way that is discreet? And do you have a private room with a phone where you can actually make a report with the youth if they decide that's something they're comfortable with? So I provided a link here with more information on reporting and the phone number to call. So after doing your initial safety assessment and responding as appropriate, it's important to identify the youth support system to both prevent ongoing trauma and support the youth in treatment and recovery. So this could include identifying safe family members, and in King County, we have a variety of home-based, school-based, and community services for youth. So depending on our clinics and our practice setting, we have varying levels of support to facilitate these referrals. It might be staff in the clinic. You might have an on-site multidisciplinary team. A lot of us don't have this whole team to help with that. So we can be proactive in making direct referrals to some of these services. A lot of these services also are open to self-referrals directly from youth. I think Crisis Connections is a service that I think a lot of us are familiar with, and they actually have a specific teen link where teens can text the service. So these services range from things like 24-hour crisis outreach, in-home crisis response teams that can de-escalate conflict, do behavioral health and suicide risk assessments, assist with referrals to behavioral health services. And there are also a couple of residential crisis centers for teens who are in acute crisis. So now I'm going to talk a little bit more about evidence-based therapies for trauma-exposed youth. There are several different psychotherapeutic interventions that have been studied in the treatment of trauma-exposed youth. So I wanted to mention this Cochrane review done in 2016, and the objective was to assess the effects of psychological therapies in preventing PTSD and associated negative emotional, behavioral, and mental health outcomes in trauma-exposed children and adolescents. So their key findings included the following. There was low-quality evidence that children and adolescents receiving psychological therapies compared to no therapy, waitlist, or treatment as usual were less likely to be diagnosed with PTSD and had fewer symptoms of PTSD up to a month after treatment. There was moderate quality evidence that CBT, cognitive behavioral therapy specifically, might be more effective at reducing PTSD symptoms compared to other therapies for up to 1 month. And in a separate review that was done in 2014 that specifically looked at trauma-focused cognitive behavioral therapy in trauma-exposed children and adolescents, they found high-quality evidence that trauma-focused CBT reduces PTSD symptoms over time. So they looked at studies that measured outcomes up to 12 months after therapy. And there was moderate quality evidence that trauma-focused CBT reduced symptoms of depression compared with controls and increased effective parenting practices and parents' emotional reactions to child's abuse over time. Because trauma-focused CBT has the greatest amount of evidence, we're going to focus a little more on that during this presentation. So the majority of us won't be providing trauma-focused CBT, but as primary care providers, we can offer a lot of psychoeducation and anticipatory guidance to both support patients and families while they wait for services and prepare them to engage in services. Trauma-focused CBT, it's done, it's a stepwise approach separated in 3 phases. So during the first phase of stabilization, patients and their caregiver will go through these sessions in parallel. They'll receive psychoeducation about trauma, review parenting skills, relaxation skills, affect modulation to help process those negative emotional states, and cognitive processing to recognize and replace maladaptive cognitions related to their trauma. During the trauma narrative, they will form their trauma narrative and use the skills that they learned in the stabilization phase to help process those emotional states and maladaptive cognitions. And then during the third phase, the consolidation phase, they'll have joint sessions with the patient or client and their caregiver or parent to share that trauma narrative. It's an opportunity to ask questions, and therapists can help model optimal communication between the youth and caregiver. And with trauma, there is often a loss of safety, betrayal of trust. So this is also an opportunity to rebuild that trust and work on a safety plan moving forward. Moving on to pharmacotherapy, we wanted to highlight a few considerations that are important for trauma-exposed youth. So the evidence is different when you're looking at treatment of mental health diagnoses between children and youth and adults, so they should not be treated as adults. They may not easily fit into common diagnostic categories, which can make it more challenging to choose the appropriate medication to alleviate their symptoms. They tend to be overtreated with medication, so children and youth enrolled in Medicaid are at least 2 to 3 times more likely to be prescribed psychotropic meds compared to their counterparts who are not in Medicaid. And there's also over-treatment in children and youth in foster care, and that it's thought that this may be an attempt to control any disruptive behaviors that could potentially threaten placement. So in response to this, child welfare agencies have adopted programs to provide more oversight for prescription of psychotropic medications in these populations. Trauma-exposed youth also may be more susceptible to adverse effects associated with psychotropic meds, such as weight gain or suicidality. And youth who are still experiencing trauma are unlikely to benefit greatly from medication. The symptoms of things like increased reactivity, hyperarousal, and poor attention are all part of a normal stress response to an ongoing threat. So we should, for children and youth in this position, we should concentrate, again, prioritizing their safety and prevention of ongoing trauma. This slide is mainly here as a reference, since we would hopefully be working closely with therapists and psychiatrists when treating trauma-exposed youth who may not be responding to psychotherapy and potentially need medication. And this information, it's abstracted from the Florida Best Practice Psychotherapeutic Medication Guidelines for Children and Adolescents, and they basically put out recommendations every 2 years for psychotherapeutic med prescribing that's based on the latest evidence and clinical consensus. And I did just want to highlight ADHD because that's something that's not uncommon in primary care. And it's really important to screen these young people for trauma because, again, those symptoms that they're having may be related to traumatic stress. And if we treat them for ADHD without addressing any underlying traumatic stress, then that could potentially exacerbate their symptoms. So as Mike mentioned, there's a wide variation in the way that children and adolescents respond to trauma. While some go on to exhibit various psychological, behavioral, and physical consequences, others are relatively unaffected. And resilience has been suggested to explain some of this variation. The American Psychological Association defines resilience as the process and outcome of successfully adapting to difficult or challenging life experiences through mental, emotional, and behavioral flexibility. And adjustment to external and internal demands. So there's been a lot of research looking at how resilience factors lead to good outcomes despite risks. And more recently, there's been a focus on how we can promote resilience. Some of the limitations with the research are that different researchers will use different definitions of resilience and use a variety of outcomes measuring resilience. So some of those outcomes might be decreased negative outcomes, so lower delinquency, substance use, um, antisocial behavior, depression, anxiety, or more positive outcomes such as behavioral functioning, academic achievement, or positive relationships. So in one review from 2019, looking at factors associated with resilient outcomes in children exposed to adversity, researchers found several factors associated with resilient outcomes. So just to give a few examples, on an individual level, things like problem solving, self-esteem, on a family social level, having positive relationships either with adults, friends, or partners. In a school setting, having positive student-teacher relationships, and on a community level, having a strong sense of social cohesion, have all been associated with resilient outcomes. So how do we take this information and incorporate it into a clinic visit? Dr. Kenneth Ginsberg is a pediatrician who specializes in adolescent medicine, who authored this book, Building Resilience in Children and Teens, Giving Kids Roots and Wings. So a lot of these C's seem really intuitive, and a lot of us are probably incorporating these into our visits already, but it's a helpful tool that we can use. So just to give a few examples, things like connection, we can help young people explore positive relationships, whether it be with family members, friends, or partners, because those strong relationships can offer security that allows them to face challenges on their own. And things like contribution, if they have an interest in service activities or feel like they're already contributing either in the home or on a team they're a part of, it can be really powerful when youth realize that the world is a better place because they're in it. So to summarize, trauma is common. We as primary care providers are uniquely positioned to screen for trauma. CATS is one tool that we can use in our primary care setting. Trauma-informed practices are essential to reduce the risk of re-traumatizing youth in the healthcare setting. Psychotherapy is a first line for trauma-exposed youth, and we as primary care providers can help promote resilience in youth. And I've listed some of the King County Youth Services here, and they're all hyperlinked and should be available in the S Drive. And we also listed a few clinical tools for the primary care setting. So we wanted to thank our patients who share their stories with us and inspire us to be better doctors, the Seattle Science Foundation for hosting this event, Jasmine Zavala, who has been, she's our adolescent medicine specialist at CMAR. She's been a great mentor and is a really helpful resource whenever we have questions about our adolescent patients. Angie Tamayo Montero is our integrative mental health therapist at CMAR. Shannon Waterman and Barry Saver, our faculty advisors for this presentation. And it looks like we, here are references, and we'll see if we have any questions.
This is Barry. I know there was one question from Kristen to Mike, and I didn't quite catch which slide it was on because it showed up in a place I wasn't looking, so I only saw it a couple minutes later, but asking, maybe Kristen can clarify, asking if they separately look at age of exposure and risk of developing PTSD or number of traumatic exposures. Kristen, maybe you can type in clarification if that's not, oh, when talking about the meta-analysis.
Well, let's see. When talking about the meta-analysis, they did not specifically, in terms of the meta-analysis that showed kind of like which adolescents are most likely to develop PTSD, like those who are exposed to interpersonal trauma, for example. That meta-analysis did not, in my understanding of it, did not necessarily break down like number of traumatic experiences or experiences to multiple types of trauma, and it did not necessarily break it down based on age, at least in terms of what was like age of exposure, in terms of what was considered to be significant findings from that. There may have been more data that was analyzed that could have showed some further information about that I did not notice when I read through it.
Okay. So far, there are no other questions I've seen. There was one comment from Rich Kovar. First, just saying, great job, guys. But also saying it's important to understand your focus on adolescents. It's important to distinguish between youth with intact childhoods who experience trauma and those whose, experience trauma in adolescence, and those whose abuse, neglect, and trauma begin in early childhood before primary attachment relationships solidified, such as including intrauterine drug exposure, complex trauma, etc. I don't know if you have any particular responses or comments, but thanks, Rich. Oh, and if you don't have anything, Julie Teraday asks if you recommend administering the CAT screen orally.
So I didn't specifically find information about administering the CAT screen without it being completed, written in a written format by the youth directly. I think that could be. It's possible that could be an option. I just didn't find anything particularly on oral administration of the questionnaire.
Yeah, and I don't know anything specific about that, but in general, there's a lot of research showing people are more likely to be self-revealing about sensitive issues on written or computer-based surveys than an in-person interview. So my guess from that would be, since this is quite sensitive, you're more likely to get people to self-reveal if you have them do it written. Let's see, is there anything else here? Oh, and then if people just look in the chat about how to claim CME credit, I guess I better do that too. Okay. But the instructions are there in the chat for anyone who's listening in. Oh, and there it is. Not seeing any other questions.
Thank you so much for being here.
Thanks, everyone.
And thanks so much for doing this. Great topic, great talk.
Good job, everyone. Thank you.
Thanks for watching. Hit the subscribe button for more medical content.